So we'll just go ahead then with our last session. So this will be one of our session that we have dual knowledge and a grade 2 society joining us together. Today is Jim and CBRIP, and it's my pleasure to have Dr. Antonio Colombo with us here and Dr. Mohammed Subhi. And I would like to invite Dr. Khalid Bindani and Dr. Musa Akbar, and also Dr. Abdullah Shihab if he's around. And the session will be the dual knowledge Jim meets CVRIP. Without any further ado, we'll start with our first presentation by Dr. Antonio Colombo about complex coronary intervention using drug-coated balloons.
Okay, I move there.
Yeah, please.
Thank you very much. It's really a pleasure, and congratulations for this very interesting and teaching meeting. It's amazing that you always learn something even after so many years. I have 3 cases to demonstrate the value of utilizing drug-coated balloons in complex lesions. And please, during the presentation, you can stop and ask a question because I think it will become more interactive. The cases are number 1, 2, 3, so I think we have the first case. So this is it's an LED lesion. I run it. No, I want to run it again. Okay, how do you go back? Okay, I learn. Okay, so normally you would place a long stent, maybe a 38, and then another stent, or just stent from here to here. Let's see in another view. This is a more classic view. So what would you normally do with this lesion? Predilate, do IVUS, do OCT, whatever, but...
maybe we'll just run by our dear panelist, Dr. Subhi.
Yes, without Colombo technique, usually I do this predilatation from distal to proximal, from the most distal part here, not very distal part, distal, and then by 1.5, and then 2 balloon, and then see what's going, and then starting by 2 stents overlap. This is usually before decision. I'm not doing imaging in such cases. I'm not doing FFR, but just what we're doing every day.
Musa?
Well, I think with this diffuse disease from proximal to distal, what I intend to do, we balloon it, but the critical lesion proximal, I stented, and then the distal, I'll try to reserve it for the future. If any surgery, then do drug-eluting balloon for the distal.
So you would stent proximally and doing drug-eluting balloon more distal?
Well, I mean, you can start from the distal part, after the third septal with a small balloon to predilate, and then you can go higher with a bigger balloon, 275 at the proximal part, and see what happens.
So we, at this time, this was done quite a while ago, maybe more than 1 year ago, we had not very reliable pressure wire that every time you connect and disconnect the pressure wire, you may lose the calibration. So at that time, we utilized the 2 wires. We left 1 pressure wire distally to monitor the pressure, so you never detach and attach, because at that time the pressure wire were not very reliable. And then we had another wire that was the workhorse wire. So the distal wire to monitor the pressure was a way to see if we were doing a good predilatation and what was the residual gradient. Then proximally was very calcific. We did a cutting balloon at high pressure. And the vessel we looked with IBUS was very large, was 4 millimeter. So we placed a drug-eluting stent proximally, as you said. And then we had these so-called not acceptable result distally. You see there is a lot of dissection, and this imperfect result is confirmed by the presence of a PDPA of 0.82, which means that you have a gradient of 18, which is, in our experience, is not acceptable. So at this point, most of the people would have placed additional stents. What would you have done at this point? You still did not use drug-coated balloons.
So it's still there is a dissection.
Yeah, there is a dissection.
Yeah.
When do you say this is non-occlusive dissection? When you have this, you are from this.
But this dissection is not a benign dissection for two reasons. For one reason, because there is still a residual big gradient. As I said, there is 82. As a matter of fact, the confirmation that this is not a benign dissection and 82 is not acceptable is that few minutes later you have distal occlusion.
Okay.
So here you have a distal occlusion. Thanks God you still have the wire in place, so this is not a big problem. So at this point, I think you have a dissection, you have a PDPA, which is 82, which is not acceptable. You have a distal occlusion. I would say most of the people would have placed a stent.
Yes, yes.
Probably, yeah.
Yeah, I think we'll looking at it. It has a dissection, and the size of it can accommodate a stent, and you already have an artery that occlude within our eyes. So putting a stent is the way to go. Although I'm sure that you did something else.
So we did additional balloon dilatations.
So what about the prolonged balloon inflation?
Yeah, we did prolonged 1 minute, 2 minutes, something like that, not too long, but 1 minute. And after additional balloon dilatation, still PDPA was 82. The vessel reopened, but still was 82. That is not acceptable because we don't have any randomized study, but our 2 years experience is that we do not accept any residual gradient higher than 10. So we did additional dilatation, and after additional dilatation, we got a stable gradient of PDPA of 91. And this 91 at times went to 92, 93, sometimes 94, 92. So at this point, we did the drug-coated balloons. There is still a dissection, but you see the lumen. I need to, okay, the lumen is much better. The distal vessel is fairly large. So we went away with one single stent dilated at 4 millimeter, which is very encouraging, with an excellent distal flow. The pressure wire is at the very, very distal and was 91 with a PD. And I must say that 5 millimeter of gradient is given already by the stent. When we did the pullback of the wire, when we reached the distal end of the stent was 96. So 4 millimeter of mercury of gradient was already present in the stent. So the gradient created by the dissection was only 4.
I see. So you went with a 2.5 balloon, or you downside the drug?
We went
balloon?
with the 2.5 and we did a trio drug-coated balloon in the mid and the 2.5 more distal.
It looks like even you did not lose the septals. The septals were like still patent. The small septals at the distal part, the septal perforators.
Yeah.
Yeah, still patent
Yeah,
after
the
the drug.
septal, you see that all the septal, I don't know why. Let me show also some other projections because look in this other projection is stable, 91, 92. There is a dissection, but you see that the lumen is well maintained, so you can achieve a good result. You may argue, what's the problem to place 2 long stents? It would have been easier, quicker, and I only believe that you need specific studies to demonstrate that this approach has some advantages. Of course, these are anecdotal cases, but I show you also this projection. Okay, I think it's enough.
Antonio, regarding the DCP, do you have any choice between the paclitaxel or sirolimus, or in your experience?
But we don't have any data yet to show that one is superior to the other. But these, to me, this example does not show effectiveness, because in order to show effectiveness, you need 1 year data, so we need the follow-up. But I think this approach shows safety, because now we have more than 150 patients with complex lesion treated in this fashion. We have a publication being printed shortly. So I think safety, I'm pretty convinced. Effectiveness, we don't know.
We'll take a question from audience, Dr. Hani.
Yeah. Well, I'm impressed. And I also see history being repeat itself. But nonetheless, we need a word of caution that what the master does in his own practice is not going to be replicated easily by others. And I just worry that people might see what you're doing and run the risk of having complication because they are trying to follow the master of 40 years experience and then fall on their head and in face and don't achieve the same results as you're having. And I am delighted, but I think the generation that can do that in this room will be very few, Anthony. And that's where I feel that congratulate you for that, and great results, and I have no qualm about saying that this is a great outcome. But what I'm concerned about is that the outcome in Antonio Colombo's hand is very difficult to achieve in other people's hand. Thank you.
But the reason why we utilize the pressure wire is to take away the subjective element. Because if you rely on the personal evaluation, is this dissection good, is this dissection bad, then you are prone to make a mistake. If you have an objective number, which is a gradient, that is less likely that you make a mistake because you have a number, and if the gradient is 5, 6, is the positive information, and you take away the personal judgment.
Okay.
Professor, with this kind of dissection, how long it takes to have a complete healing of the vessel? Does it take as early as 4 weeks?
Not always you have a complete healing. Sometimes you do not have complete healing, but still at the follow-up, after 1 year follow-up, we saw dissections with double lumen still present. We have to understand that when we give an additional drug like sirolimus or paclitaxel, in somehow we affect also healing. So not necessarily every day, but the fact that it doesn't heal is not a problem. As a matter of fact, a patient with a non-healed dissection may be better doing than a patient with a healed dissection because there's 2 lumens. Okay, let's go to the other case. Case number 2. I close this. Can you click on case number 2, okay? Case number 2. Okay, so this is a 56-year-old male, effort angina, stable, ischemia only on exercise, normal EF. So he's a patient that could have been managed medically, but we did intervention. You see, there is a severe stenosis at the ostium of the circumflex. The circumflex is dominant, and there is a long diffuse disease on the LAD. The patient was treated in two sessions. One session was stented. The ostium of the circumflex is basically no left main, like 2 separate lumen with a single stent, 4 millimeter, and then we tackled the LAD. So this is a typical case that we approach with a pressure wire from the very beginning. Now with contemporary pressure wire, you don't need any additional wire. You can use the pressure wire from the very beginning. We do imaging in order to assess the size of the vessel, what type of strategy you want to use, etc. We wire the diagonals because we do not want to lose any branch. We did the pressure wire on the LAD. And we did imaging. You see there is a fair amount of calcium in the proximal and mid LAD. We did pre-dilatation with a non-compliant balloon at high pressure. Here nothing new. We protected the diagonal. The balloon expanded here, and here is not completely expanded. We went into an orthogonal projection, which is always very important, and you see that the balloon is not well expanded. We went to a higher pressure, the balloon ruptured, but finally we were able to achieve a good balloon expansion without the need of lithotripsy or any additional device. So here is nothing new. The lesion is apparently well prepared, and we measure the distal pressure gradient at this point, and is 0.90, so it's not bad for such a diffuse disease. LAD with a DFR of 85. We repeated the IVUS, and you see that the calcium is broken. There is a dissection, but the pressure gradient is stable. As a matter of fact, now is even 91, and the gradient is stable. So at this point, because the gradient is stable, we use a drug-coated balloon proximally and mid, and the gradient after drug-coated balloon is even better. Now the PDPA is 94, so the fact that during the procedure you see that the gradient, instead of going down, instead of going up, goes down, which is the opposite, and we left it as it is without any additional procedure. I think we go to the last slide where you see And in this case, I need to... in this case, we didn't implant any stent, and the final gradient was 94. So this is another example of treating diffuse LAD disease without stenting, with PDPA as a reassuring element of safety.
Just a question for you, Dr. Khalid. So if you have a PDB or the gradient less than 10%, and you're happy with the result, what is the chance that this will get worse with time? Like within, I mean, hours or the first 24 hours?
I can only, I mean, we have, as I said, we have a publication of 80 complex lesions where nothing happens, and this is a publication that went out 6 or 7 months ago. Now, instead of 80 lesions, we have over 200 lesions, and so far we did not see a single event. We are waiting to have follow-up because besides the acute event, we need a 1-year follow-up, and when we have a 1-year follow-up, we'll have another publication. But so far, I tell you that if the gradient is stable in a matter of 2 or 3 minutes, we don't have a deterioration. As a matter of fact, we have an improvement.
Antonio, I think you have a trial which is called the Bailout trial, something like that in the past without wiring, only DCP for the distal vessels.
Yeah.
Am I right?
Yeah, but now we put the wire in the pressure in order to have an objective element and take away the subjective evaluation.
So in your opinion, this will replace what could be claimed in the PVS in the distal vessels? Because when starting the PVS, it said that, okay, in the LAD distal, it's better to put a PVS because this should be absorbable within 2 years or something like that for the LIMAP.
But I say that in some situation, it may even replace stents in the proximal lesion.
Okay.
I mean, this is not to go against stenting, but to go against stenting when you don't need it.
Great. We'll
Okay,
take the question from
the LED has some calcium, and the LED was having some calcium, and you pre-dilated it, and then you used the DCB. So is there any data regarding DCB with calcific lesion in such situation?
This is a big discussion. Does the DCB work in calcific lesions? I don't know. You need to be patient. In a couple of years, I can give you the answer.
Sure.
But let me show you the last case, which is quick, is the short. The message of the last case is that in some situation, this approach may even be simple and quicker. Can you show?
While you're getting up the slides, Dr. Colombo, one question. What's the bailout stenting rate in your series?
The bailout stenting rate is less than 10%. It's about 8%. It's about 10% hybrid strategy and 6-7% bailout stenting rate. Okay, this is so this is a complex bifurcation that is really, we didn't measure, it will come, it's like a movie, you have to be a little bit, okay, you see that the left main with an old stent in the proximal LAD and the quadrifurcation of the left main. Here it's a lot of work. If you do stenting, most of the time we will do stenting from the left main to the LAD, then provisional, we place 3 wires. We did lesion predilatation, and the results were so good after predilatation that was very difficult to, and so we used 3 drug-coated balloons.
So
And,
one was in the LED and one was in the circ and was in the ramus, or
Yeah.
the 2 ramuses you also
Yeah.
ballooned them.
So this is and this procedure was done in 20 minutes. This was done 8 or 9 months ago. Patient is doing very well. We wait 1 year to do a CT scan to recheck, but here there was no dissection. The result was very stable. We waited 10, 15 minutes to make sure that there was no recoil, but
The ballooning was 1 by 1, or you went with
one to one.
one
to one.
1 to 1. I mean, you wired the 4 of them, and then you ballooned 1 by 1, or
One to one.
1 to 1.
But they always ask the lesion preparation strategy, is that aggressive? Is not very aggressive. Is not very. We do not want to purposely create a dissection. If we get a good result without creating a dissection, we take it. But if we create a dissection, we evaluate if the dissection is benign or not. That's the difference. We don't purposely create a dissection, but not every dissection is considered a stented dissection.
Great. We'll take a question from Dr. Samih before we end up this talk.
Thank you, Professor Antonio. This is the topic of my love, I call it. I've been involved in drug-eluting balloons for a few years, and I'm not counting how many I've done, but I have cases like where 5 to 6 drug-eluting balloons in multi-vessel patients. My comment is that I've noticed lately that using a scoring balloon instead of NC balloons have reduced the chances of 2 things. One is dissection, 2, recoil. And when I've continued to do it, I've seen much less evidence or developments of dissections and or recoils, to the degree that I'm more encouraged to use more drug-eluting balloons only after using DSC scoring balloons, and became now a de facto approach. What would be your take on that?
I agree. I think a scoring balloon or cutting balloon can be very helpful in the setting of usage of DCB. So I think I don't know if we have to do a randomized study on every sentence we say, but I think scoring balloons are effective. They are a little bit expensive, so we don't use them routinely, but they are definitely an advantage.
Antonio, do you think that we are in 2023? The position statement of DCP now is going to replace, in my mind, going to replace the PBS. Ostial lesion can be used for DCP. In-stent restenosis already in the guidelines. Now we are adding this diffuse disease. But what we are not sure of it is the native vessels, I mean the proximal vessels. We are afraid to make it this. I think, do you need a randomized trials to make it this? Because already ostial is not bad to make it. Diffuse okay, in-stent restenosis. Then now is just missing the proximal or the native vessels. How can you to be sure that this can be used in such vessels, or maybe in big vessels, 3 millimeter, 3.5?
But you know, there are many questions. I'm not so sure that all these questions that you pose will be answered in my lifetime. But first of all, we need to understand which is a good DCB. Because, you know, there are so many DCB. Now we know that DES are very similar. We still don't know. So we may do a trial with a DCB and then discover that the trial is negative because we didn't use a good DCB. So first of all, we need to know the DCB. Second, we don't want to do a trial against stenting because the stents are good. So we are not against stenting. Let's make it clear. We are against stenting when you do not need a stent. Now we are in a mature phase where we can do a good job even without a stent in every lesion. There are some lesions where if the result is good and is stable, you may not need a stent. But we need to show that there is an advantage. In the left main I showed you, there is an advantage immediately because it took half an hour. Instead of placing a stent, you triple inflations, etc., etc. In some other situations, maybe there is no advantage, but it's going to take 4 or 5 years before answering to all your questions.
Thank you much, Prof. Antonio. We cannot get enough of you, but I have to move on. Maybe we'll just take a final comment.
Yes, Antonio, very interesting concept. You taught us this for the last few years. Now, we need to be safe. And my question to you, what are your criteria for indicating bailout stenting? When do you think this should be stented?
Okay, the criteria are, one, if I see an occlusive dissection, that I do one trial with the prolonged balloon inflation, and if after the prolonged balloon inflation I still am not sure, I go for stenting. Because again, my goal now is safety, so I don't want to take any risk. So if I see a dissection that is angiographically not good, I go for stenting. And the other criteria is that if I measure with the pressure wire and I see a gradient higher than 10, higher than 8, 9, I like 92, 93. And also I like to see that after a few minutes, the gradient, instead of going up, goes down. In 90 becomes 92, 93. So these are the two criteria. Bad dissection angiographically and the gradient that instead of getting less, goes up. So these are the two criteria for stenting.
Thank you very much, Prof. Antonio Colombo.